Uh, Good morning, everyone. Today, the class will be on case capsule on the bile duct injury. And today's our moderator, Dr. Pattnaik. He is Associate Professor, Department of Surgical Gastroenterology. He is also Head of Department at AIIMS Bhubaneswar. And today's class will be moderated by Dr. Pattnaik, Dr. Rajendra Desai, sir.
Good morning, everyone. Myself, Dr. Azhar, MCI second year resident from AIIMS Rishikesh, sir. So, this is my patient particulars 29 years old female patient, occupation by homemaker, and she is a resident of Roorkee, Uttarakhand. She presented to us with the chief complaint of bilious output from the percutaneous drain in the upper abdomen since 3 months following laparoscopic cholecystectomy. The history of patient illness: patient had history of pain in the right upper quadrant since 2 years, for which she was evaluated and diagnosed to have symptomatic gallstone disease in October 2024 at outside hospital. Following, she underwent laparoscopic cholecystectomy 3 months back on 7th October 2024. The operative period was uneventful as per patient attendee's information, and there was no drain was placed. Duration of the surgery was about 90 minutes, and there is no history of any perioperative transfusion of blood and blood product, and she was discharged successfully on the next day. Following discharge, on after 2 days of surgery, patient developed earliest discoloration of eyes, and following that, on after 9 days of surgery, she also had complaint of low-grade fever, which was not associated with chills and rigors. But the fever was associated with mild upper abdominal pain, which was dull, aching in nature, continuous, and which was non-radiating, and it was relieved with oral medication. And following that, she again attended the OPD of the same hospital, and she was readmitted in that hospital. And following some basic investigations, she was an attendant of the patient or informed that patient is having bile infection. For that, one percutaneous drain was placed after 11 days of the surgery, and immediately after placing the drain, 350 ml thick greenish yellow fluid was drained. And following the insertion of the drain, her fever was resolved over 3 days, and the yellowish discoloration of the eyes resolved over 7 days. Now, when she presented to us at patient, that percutaneous drain is draining about 450 to 500 ml of thin bright yellow fluid every day, and at patient she is passing clay color stool. The biopsy of that gallbladder specimen is negative for malignancy, and at patient there is no yellowish discoloration of eyes and urine, and patient doesn't have any abdominal pain, fever, or pruritus. There is no history of hematemesis or melena, no history of any bone pain, easy bruisability, and there is no history of loss of appetite or loss of weight. So past history not contributory, and family history also not contributory. Personal history: patient taking mixed diet with normal bladder habit, but patient is passing clay colored stool, sleep is normal, and there is no history of any addiction. So, to summarize my case, 29-year, sorry, some mistake is there. 29-year-old female with no comorbidities underwent laparoscopic cholecystectomy 3 months back. Following 2 days of surgery, she developed obstructive pattern of jaundice, following which she developed fever, low-grade fever associated with abdominal pain, and subsequently a percutaneous drain was placed, which initially drained 300 ml of thick greenish fluid, followed by gradually the color and nature of fluid changed to thin bright yellow with daily output of 450 to 500 ml. And following that, there is resolution of the symptoms.
So, Dr. Azhar, what is your what you missed in the history of present illness? Whenever we discuss about possible bile duct injuries, especially if it is conducted at a not in a tertiary care hospital or maybe in a private setup with a single surgeon. So, have you explained how you spoke to the individual surgeon later on your presentation, or you have not included that part?
Yes, sir. Once patient came to us, we checked the patient period of investigations, the discharge summary, and the discharge summary was information was not adequate in the discharge summary. So I spoke to the operating surgeon, and regarding that intra-op details, only this much only about to tell. So patient, the surgery was uneventful. Only it was 90 minutes of duration. There was no intra bile spillage, and there is no drain was placed. And pre-operative,
Whenever we speak to the individual operating surgeon, what all things you prefer to ask? Can you just make some points, 7, 8 points? What are the things you are going to ask to the primary surgeon?
yes, sir. So regarding the pre-operative status of the patient, so symptom-wise, whether patient had any history of yellowish discoloration of eyes or any history of jaundice, any history of recurrent upper abdominal pain suggesting of like recurrent biliary type of pancreatitis, patient had fever or not, and blood investigation wise, whether any there is jaundice was the bilirubin was raised or not. Even if bilirubin is normal, whether ALP or GGT were raised or not, and whether patient had any history of acute cholecystitis, whether this case was taken as a elective or it was taken as a emergency case. So regarding this are the preoperative. During intra-op, whether it was done on laparoscopic or open. If it is done on open, whether laparoscopy converted to open or from the beginning it was decided to be done in open. So whether GB was calories was frozen or not, GB wall thickness, how it was, whether it was edematous or not, whether any difficulty was there while dissecting the carrots, whether critical view of safety was achieved or not, whether any bile spillage or there or not. If there is any bile spillage, what is the color of the bile? And how much was the duration? Any intraoperative bleeding was there or not?
Okay.
Yes, sir.
Okay. So coming back to the history,
Yes, sir.
if we see on POT2, she had some obstructive symptoms, right?
Yes, sir.
That time it started with jaundice, which was progressing up to day 11 till the time a drain was put. So
Yes,
how do you see it? What kind of injury it must have been? Because initially it was jaundice, and later on it came out to be a uh, intra-abdominal biliary collection, which was drained, and after that jaundice settled. So initially, if somebody is clipping the bile duct, it must be because if it is type 2, then it will just, or type B, then it will just increase on the bilirubin will increase. Okay.
yes, sir.
But how you correlate? Initially, it was in like something was ligated. It was the history was like that. But later on, you find some biliary collection, and after drainage of the collection, jaundice improved. How you correlate? How you see this history properly? Was it taken properly, or you now also you try to modify?
No, sir. This history is taken properly. I don't want to modify the history,
Okay,
sir.
so then how do you justify? I mean, what must have happened clinically at least from the history?
Yes, sir. So likely this there was clipping of the duct, complete clipping of the duct,
Which
and
drug?
sir, common hepatic duct, complete transactional injury with proximal ligation, clipping of the duct. I likely this may be the classical bile duct injury.
Classical
I
bile
think.
duct injury. But in
Yes.
classical bile duct injury, they'll apply two clips, one in CBD and one in CSD, and they'll take it out. Okay. So
Yes, sir.
why there will be some collection of 400 ml on POD 11 and so?
Yes, sir. So there is clipping, and I think because of clipping, there is vascular compromisation and sloughing out of the clipped, followed by that bilioma may develop, sir.
What kind of vascular compromise in bile duct clipping?
Um, sir, I think that stump got ischemic and that clip got sloughed out, sir.
Can I ask a question, sir?
Yes, sir. Welcome, sir. Sir, good morning.
Good morning,
Yes,
Dr. Pattnaik. Yeah.
good morning, sir.
Azhar,
Yes,
There
sir.
are a few things I wanted to mention about the history itself.
Yes, sir.
First is please don't refer to people as female and male. You have to say lady and gentleman
Okay, sir.
because it's very offensive to hear you being called as a female or a male. And second thing is you said past history is not contributory. What past history are you interested in finding out about?
It's a very, very valid question.
Yes, sir. So, in past history, in regarding this case, whether patient had underwent any intervention or not, any endoscopic intervention was done or not, sir? Like,
That she has said she hasn't had anything. And you gave the present history, you gave it from 3 months back.
yes, sir.
Before that, you said she was apparently asymptomatic. So, what are the specific things you were looking for? With what intention were you looking for in the past history? Because you didn't mention any history of weight loss, you didn't mention any history of jaundice in the past, you didn't mention any history of pain in the past, you didn't mention any history of intervention in the past. And second thing is, why are you assuming this is a sloughed off bile duct and this is a biliary injury? Why can't it be a cystic duct blowout with a CBD stone?
That
Do you
also,
agree or you don't agree? Or if you agree, why? If you don't agree, why?
yes, sir. I agree to that also, sir. That also be a possibility. Cystic duct blowout with CBD stone, sir. That is my like first diagnosis, followed by the second, sir. Slept out, sir.
Yeah, but why would it slough off so early? Just you have clipped and then it sloughs off. It will slip off because of the increasing rise in pressure in the bile duct. It will just slip off. If only one clip has been put, it will just be dislodged and it will start draining bile. And also different types of injury where there is isolated right duct, isolated right posterior duct, abnormal opening of the right posterior duct lower into the gallbladder. So from the gallbladder bile, a duct of Lushka has been draining. All those will produce similar symptoms. Only
Yes, sir.
thing is the jaundice is because of the bile being absorbed from the abdominal cavity. You didn't mention any history of pruritus at any stage. So why do you think she had obstructive jaundice?
Sir, on day two, only she had the yellowish of discoloration, and followed by she didn't have the pruritus, but she giving history of passing uh, pale
Yeah,
color.
so 9 days she had jaundice without pruritus, without fever. So why did you think it was obstructive jaundice? And there was no clay colored stools from your history. Do you want to correct your history and your interpretation? What do
Yes,
you think it is?
yes, sir. Patient on day two I mentioned, but after that, in between, she gave history of passing pale colored stool, sir.
You need to mention these things. These things are very important. And obstructive jaundice can be because of a CBD stone impacted the lower end, which will not produce colicky pain. So you must consider all possibilities. Type of bile duct injury, you have to specify the type which are possible. Don't say only one way of explanation. You shouldn't say it's left off bile duct, it's bleeding, classical biliary injury. When the surgeon has told you it was uneventful, it was a routine case, you have to think of cystic duct blowout first with a CBD stone.
Yes, sir.
Second possibility is a type C or type C is where both are ligated. That is possible. And the ligature is slipped off. A type A type of injury can be there
Yes, sir.
where there's a collection and compression of the bile duct and duodenum. You did not mention anything about whether she was eating food normally or not. Isn't that important? Because this could be a duodenal injury. It was greenish colored bile and then it became yellow color. Was she taking food continuously?
Sir, excuse me, sir. Dr. Manoj, please mute your.
Was she eating normally after the injury?
Yes, sir.
She didn't have any nausea, vomiting, pain abdomen.
No, sir. Only she developed pain abdomen on after 9 days of
Isn't it
surgery.
important to tell that she was eating and drinking normally?
Yes, sir. I should have mentioned that. Yes, sir.
Why
That is
is it important?
yes, sir. To if it is like as you mentioned, sir, if it is a duodenal injury, then patient will not tolerate, sir.
Without duodenal injury, with bile duct injury, why is eating and drinking important? That will tell you whether this is a localized or an unlocalized collection.
Yes, sir.
If it's unlocalized, if there are multiple intra-abdominal collections, there is peritonism, there is peritonitis, then the patient will be not able to eat. They will be vomiting. They will be having ileus. They will have distension of the abdomen, all of which you did not tell us is not there. It's critically important that you tell us all these are not there. Don't get biased from the history because you know the final investigations. If you tell a history like this, it will say that you have preconceived idea of what you thought it is.
So on general physical examination, she was averagely built and averagely nourished. She was alert, conscious, and cooperative and oriented to time, place, and person. She was lying comfortably on bed. The ECOG performance score was 1. Her BMI was 22.8. At presentation, she was afebrile with normal heart rate, pulse rate, with normal blood pressure, with normal saturation and respiratory rate. Her breath holding time was 30 seconds, and there was no sign of any dehydration, and there was no sign of any liver failure.
Dr. Azhar, at what day you are examining this patient now, this physical examination?
This is after 3 months, sir, when she presented to us.
Okay.
Now, yes, sir.
Okay.
And there is no icterus at present, no pallor, sinuses clubbing, or any lymphadenopathy. On abdominal examination, on inspectory finding, abdomen is flat, umbilicus is central and inverted, all quadrants moving equally with respiration, and there is a healthy, primarily healed standard laparoscopic cholecystectomy port skirts present, and there is no visible lump, sinus, or engorged vein, pulsation, peristalsis, or any couple impulse. All hernial orifices are free. A drain is noted in the epigastric region, which is draining thin, bright yellow fluid, which is about 200, and in bag it is 200 ml at present. So on palpation, all inspectory finding are confirmed. Abdomen is soft, non-tender. Liver and spleens are not palpable. No other lump is palpable. Hernial orifices are normal. And on percussion, there is no free fluid. Liver dialysis started at fifth intercostal space, and the liver spread is 13 centimeter in mid-clavicular line. Rest of the abdomen is tympanic. So on auscultation, bowel sounds are normal. On digital rectal examination, on presence of female lady attendant, sphincter tone was normal, and pale stool staining present on gloved finger, and other systemic examinations are normal. So after examination, to summarize my case details, 29-year-old lady with no comorbidities underwent laparoscopic cholecystectomy 3 months back. After 2 days of cholecystectomy, she developed obstructive pattern of jaundice, following which developed low-grade fever associated with abdominal pain, upper abdominal pain. Subsequently, a percutaneous drain was placed in the epigastric region, which showed initial 300 ml of greenish yellow fluid, gradually changed to thin, bright yellow in nature, with the daily output of 450 to 500 ml. And following placement of the drain, there was resolution of the symptoms.
Dr. Azhar, what was the approximate size in French of that drain, epigastric drain? It was 8 French drain, roughly. You may not tell it accurately.
It is like around 7 to 8 French, sir.
Okay, just let me put it like this. Let us, it is a complete classical bile duct injury or something like that. On
Yes.
day 2, he had jaundice and fever, and it is a good setup, having all IR facilities as well. And so when day 10, they realized it is a classical bile duct injury and patient was having fever as well. So why is it not just a left PTBD? And that because left PTBD, they classically put it through epigastric region. Then
Yes, sir.
small PTBD and 350 ml suddenly come, and then gradually over a period of time, it is still draining 400 to 500 ml, and the patient's symptoms disappeared. I'm just giving you a scenario.
Yes, sir. Yeah, maybe percutaneous transhepatic biliary drainage also, because the
You please do not agree to whatever I'm saying, and obviously I'll request Rajendra sir to put you into this as well. But you just tell your current opinion regarding this.
sir, like after putting this drain, sir, our icterus got resolved, and symptomatic resolution was there, and the site of that drain is in the epigastric region. So bilioma can be formed in the laser sac also, but that is very unlikely. So most of the time bilioma happen in the right quadrant, sir. So this may be the percutaneous transhepatic biliary drainage catheter also, sir.
Rajendra sir, please, sir.
Yeah. If you had a choice of putting a drainage tube, where would you site it, which would make your surgery easier?
I'll put from the right hypochondrium, sir, and just if it is like bilioma, then I'll put as close as to the fistula side, sir. Yes, sir.
Correct answer. In this case, would PTBD be easily done?
I think it was not required, sir. So patient had only low grade fever, and so first I would have tried with IV antibiotic. I should give a trial of conservative management, sir.
Why do you want to give antibiotics?
Sir, patient had I thinking of patient having cholangitis, sir.
Okay.
Yes, sir. Yes, sir. Or maybe bilioma. So if it is bilioma, based on investigation, I just put a drain. So draining of that collection, it would have resolved. Or if patient had imaging finding or corresponding finding suggestive of like it is a cholangitis case, then I would have give this
How
antibiotic.
will you diagnose cholangitis on imaging?
So regarding this specific to this patient, sir, so there will be dilated intrahepatic biliary radical.
But how will that tell you whether cholangitis is there or not?
Can you just tell us the components of cholangitis to make it more specific? Can you just tell, sir, about the components in Tokyo's guidelines, the recent updated Tokyo guidelines? Even if you do not tell the values, it is okay, but you just tell us the components.
Yes, sir. So first is the symptoms, sir. So patient have icterus jaundice with fever. Then the laboratory values. Their first component of there is increase inflammatory marker like C-reactive protein and leukocytosis, and there will be elevated direct bilirubin, predominantly direct component, and there is history of any ductal obstruction, any stone disease, or any intervention or any stent in situ in the biliary duct, sir.
Did you try to find out what was the level of total bilirubin and leukocyte count at the time of placement of the USG guided percutaneous catheter?
Sir, on day 9, blood investigation I didn't get, sir. So on day 2 blood investigation I got, because patient was discharged, and they took the local hospital, not the same hospital. Just they got the blood investigation as the attendees were worried. So that investigation only I got, sir, from hospital where PTBD was placed. I didn't get any PTBD gram or any.
Now you have changed. Now you are telling PTBD. Are you sure it was a PTBD? You are telling it is a small setup, and you just keep things in mind, but do not commit to whatever the examiners are trying to. Maybe they're just trying to get it out from you. Just you have possibilities in mind, but do not commit to something which is maybe it is not feasible to put a PTBD in a what kind of hospital it was. If it is a very good setup, it is okay. So you just keep things in mind.
Okay, sir.
Azhar, the examiners will try to mislead you by telling you wrong things. If you agree with them, they will penalize you. Yeah. Because they will say, could it be this? Could it be that? You have to say, it can't be this because of these reasons. It could be this because of these reasons. If you know the reasons and defend yourself, only then they will give you credit. You are now at an MCH level. You are not an MS student. Questions will not be direct.
Yes,
Go
sir.
on to the investigations.
So first, I want to look the pre-op investigations and the intra-op details. So pre-op investigation, patient complete hemogram picture was normal with a normal liver function test with normal INR level with viral marker were negative. So pre-operative ultrasound was liver was normal. There is no ISBRD. Gallbladder was distended with a few GB calculi and there was normal wall thickness with normal CBD diameter and portal vein and spleen was normal. And histopathological examination of the GB specimen was chronic calculus cholecystitis. So on post-op blood investigation, what patient attendees themselves they did. So in that complete blood picture, there is no leukocytosis. On LFT, there is obstructive, predominantly direct hyperbilirubinemia is there with transaminitis with raised ALP and GGT with albumin level of 3.3 and INR was 1.2 with normal creatinine.
Which day is this?
Sorry, sir. This is
Which day of surgery?
post of day 2, sir. Yes, sir.
Day 2. Okay. So,
So
what
I
do you mean she has raised SGOT, SGPT?
Sorry, sir. I didn't get, sir.
Why is there raised SGOT, SGPT?
There maybe, sir, subclinical cholangitis maybe on that day, sir. Or in day 2, sometimes.
Patient had pain, patient had jaundice, and according to your Tokyo criteria, all the criteria are fulfilled. Why do you say patient was not having cholangitis? Patient has cholangitis.
Yes, sir.
It's in defense of cholangitis. Raised SGOT, SGPT is seen in acute biliary obstruction, not just in cholangitis. In any acute situation where the bile duct pressure rises rapidly, you can get a raised SGOT, SGPT. That also includes cholangitis. It also includes sudden obstruction of the lower end by a bile duct stone. So at this level, you cannot rule out a bile duct stone that has slipped. As you said in the ultrasound, there are multiple stones in the gallbladder, which
Yes,
makes
sir.
it likely that they have slipped. You did not mention the size of the gallstones because that is also important. Dr. Pattnaik, any
yes, sir.
questions?
Very good point for sir was making, and I was also trying to give a hint when I was mentioning about Tokyo's classification, Tokyo's guideline, and it gets updated every 3 to 4 years. See, even if a bilirubin is 28, like chronic obstruction, C ampulla or something like that, you see the SGOT will be 30-40. Okay. But once there is raised transaminitis, it has to be an increased pressure because this AST and ALT they get released from the hepatocyte itself into the circulation inside the liver and they get reflected in blood test. So whenever there is SGOT or GPT, there must be increased pressure inside the liver cells. Okay.
Yes, sir.
So that may be due to acute obstruction. To me, it is just looking like a slipped CBD stone into the CBD. So once there is SGPT and SGOT, you have to keep cholangitis in mind. Okay.
Yes.
Obviously, acute increase in pressure because of obstruction or cholangitis. So whenever we speak about cholangitis, we always focus on the jaundice or total platelet, total leukocyte count and things like that. I have also interacting with so many residents now, but this SGOT SGPT correlation with the interpretation of the SGOT SGPT into the clinical picture is very important, where we most of the time miss the maybe milder version of cholangitis and we neglect it because we find the bilirubin is normal 1.8 or 2, the TLC is normal, but if the SGOT or SGPT is increasing, that is a thing where you can catch things before they go wrong at MCH level at least. Extremely good point what sir has tried to make it.
So I would like to know the post-operative ultrasound, immediate post-operative ultrasound before putting that percutaneous drain, but unfortunately that is not available. So this is the patient investigation after 3 months once he presented to us. So in that complete hemogram is showing a normal picture, and in LFT liver function test pattern, it is almost normal, only with mild elevation of the alkaline phosphatase and GGT level. With normal, with albumin level of 3.3 and INR is 1.6 with normal creatinine level with normal electrolytes.
Dr. Azhar, let me interrupt you for a few seconds. Whenever you are putting values of ALP, just put the normal lab values, because rest of the things are okay when it comes to bilirubin or transaminase. But this alkaline phosphatase is entirely different from lab to lab. Like at AIIMS Bhubaneswar, it is 120, the upper normal.
Yes.
And the good diagnostic centers, they have 350. Somebody is using 260. So always try to put the normal value, upper limit of alkaline phosphatase specifically.
Sure. In our institute, sir, normal ALP is upper limit of ALP is 118 and GGT is, sir, 38, sir.
Go on.
Yes, sir. So and this is the ultrasonography abdomen after 3 months. So in that, liver size is normal with normal shape and echo texture. There is no focal lesion, and mild central IHBID is seen with the PTBD catheter seen in the left ductal system, and GB bed is in gallbladder is absent, post cholecystectomy status. Common hepatic duct not visualized, portal vein and spleen are normal.
Why you want to see spleen and portal vein? It is a good finding, but why you want to see?
Patient from preoperative period, patient itself may have the some form of hepatic decompensation, or patient may develop secondary biliary cirrhosis also, sir.
Pre of hepatic decompensation, I could not get it.
Like so in bile duct injury.
You can just tell secondary biliary cirrhosis, it might be, that is okay. Why are you dragging yourself into unnecessary this thing, no?
Yes, sir. Like secondary to look for any secondary biliary cirrhosis has developed or not. Yes, sir. So after that, we proceeded with. I will proceed with the MRCP imaging, sir. So this is the coronal section of the T2 MRCP imaging, which showing the dilated.
Why didn't you do a tubogram? Why do you want an MRCP? There is a PTBD tube in situ. Why not do a PTBD gram? It's simple, obvious. Any difficulties or dangers?
No, sir. It can be done also, sir. But,
Not afraid of cholangitis?
yes, sir.
Already patient had features of cholangitis, and now you want to inject again dye under pressure into the PTBD system.
Yes, sir. Patient
If
may.
there is a high injury, left duct and right duct will not communicate with each other. It is written only central IHBRD. Peripheral IHBRD is not seen.
Yes, sir. Patient may develop contrast-induced cholangitis. Yes, sir.
But you can give antibiotics, prevent it, and then do it. It will give you more information. It will give you an idea about the stump. It will tell you what are the deficiencies of MRCP.
Sometimes MRCP can, sir, underestimate or overestimate the level of injury, sir.
So again, that's an argument in favor of PTPD. Why do you do MRCP?
I want to get the complete intrahepatic biliary duct picture, sir.
That you will get even with the PTPD gram. If PTPD gram is not communicating with the right side, then you could probably do a MRCP. That could be a justification for MRCP.
Yes, sir. I got it.
How do you do a PTPD gram?
Sorry, sir.
How do you do a PTPD gram? I tell you, I'm a consultant in your unit.
Yes,
I tell you, please get a PTPD gram for this patient. What all steps will you take to do a PTPD gram?
First, sir, I will. I will see the bile is draining from the PTPD, whether it is clear bile or not. Then second thing, I will confirm that patient doesn't have any features of cholangitis, then I will confirm the position of the PTBD. Yes, sir. Then I will procedure. I will give fluid to the patient, and I will give a single sort of an IV antibiotic, sir. And after that, I will take the patient for PTBD.
What antibiotic you want to give?
Sir, if patient, I will prefer cephalosporin sulbactam as our institute.
Straight away.
Sorry,
Straight
sir.
away, you will give cephalosporin sulbactam in all patients. You have a PTBD gram. Why don't you do a culture? Already there is history of cholangitis. Get a culture done. Rule out infection. Or if there is infection, what is the sensitivity pattern? Give the appropriate antibiotic. You want to do under fluoroscopic guidance, or you want to take just a single shot X-ray?
I want to get, sir, under fluoroscopic guidance, sir.
Why?
Like that, because, sir, if PTBD catheter is from the confluence in the same setting, I will ask my IR colleague to put it more proximal, as close as to the biliary hilum or stricture side, sir. So it will help in intraoperative.
When a tube is draining well and simply, you should not change the position of the tube.
Okay.
If it is there in that location, fine. But you can't aim for that location. That's one thing.
Yes, sir.
Second thing is, PTBD gram, if you don't do it under fluoroscopic guidance, there is a chance of over distending the bile duct. Because over distension, again, that can spark off cholangitis. Second thing, you want to opacify all bile ducts in different positions and check whether all the bile ducts are getting opacified or not. What is the importance of that? Tell me Strasbourg classification.
So type A injury is from the ducta plasca or any subvesical duct, sir. Type B is ligation of the aberrant sectoral duct. Type C is the cut injury, not the ligation of the aberrant duct, sir. Type D is the lateral injury in the common hepatic duct or common bile duct. And type E is the complete transaction, sir.
Classify type E. Classify type E. Type E is further classified, isn't it?
Yes, type E, sir. Further, if type E1 is when the biliary stricture within like 2 centimeter from the hilum, but it is within 2 centimeter from the hilum. E2 is
within 2 centimeters or more than 2 centimeters?
Sorry, sir. More than 2 centimeter from the hilum. E2 is within 2 centimeter from the hilum with confluence pattern. And E3 is the where the floor is patent, sir. Again, E3 is subclassified as good E3 and bad E3. Good
floor is involved or roof is involved? Roof is not involved.
Roof is intact, sir. Floor is involved. Yes, sir.
Yeah.
And E4 when there is ductal separation, either bifurcation or trifurcation. And E5 is this ductal stricture with associated with aberrant ductal injury.
Okay.
Yes.
Dr. Abhijit, please mute yourself. Dr. Abhijit. So, this is a very basic and very important question was Rajendra sir has asked about the position of different positions of the patient while doing PTBD gram under fluoroscopy. It's very, very important. And just let me know, suppose you are doing the ductal separation is there and you are planning for MRCP. So you straight away go for MRCP or you take some thing into account before because MRCP is costly at many places, including at our hospital also, it costs around 3,500 rupees to the patient.
Yes.
So what I think it is always better to rule out other collections by doing an ultrasound just before doing a PTBD, doing an MRCP, because in presence of GB fossa collections, everything will appear white, T2 hyperintense. And then you have to repeat the MRCP few days later on as well. This is also one of the shortcomings of MRCP. because
थोड़ा
everything will be
कमी
taken
करा
away.
161 आहे का आर्टरी लाईन वर तेच की
Dr. Abhijit, please mute yourself. Dr. Abhijit,
येस सर
please mute yourself. So this is also one of the pitfalls of MRCP. You do not straight away go for MRCP. Rule out whether it is a controlled fistula or not, and then you just go for MRCP. Obviously, PTVD will give you more information, PTVD gram, and suppose there is separation and you are suspecting some isolated duct is there, because you are not, PTVD gram is normal, even if it is not fitting into the picture, then you can obviously go for MRCP. Okay?
Okay, sir. Yes.
Please
Why do
proceed.
you think the surgeon there got a PTBD done and not a ductal drainage? Not just a right hypochondriac drain.
First thing, sir, based on history, after putting that patient icterus got resolved, sir.
No, you're not getting my point. Why was a PTBD done and not a tube drainage? Was there a collection? At no point have you shown collection.
Yes, sir. Collection was not there, sir.
So if collection was not there, why do a PTBD? Do you prefer to do a PTBD in a non-cholangitic patient with just complete transection of the bile duct?
No, sir. I
Why
want, until unless patient doesn't have uncontrollable cholangitis, I will not, because this may decompress two things. Sorry, sir. This may decompress the biliary duct, sir. So it will give
That is not correct. You want that fistula to close. There is no intra-abdominal collection. So drain has to be put in the PTBD. That will encourage the fistula to close. And then you block off the PTBD and allow the system to dilate if you want a dilated system. Second thing is,
Hello.
it may not be possible to do a PTBD if there is an undilated system. But central IHBRD is there, so they have done it.
சரி அந்த மெடிக்கல் காலேஜ் முன்னாடி வந்தீங்கல்ல
Dr. Karthikeyan, please mute yourself. Dr. Karthikeyan. Dr. Karthik. Yeah, please
Dr.
proceed.
Dr. Pattnaik, please.
Yes, sir. This is a very, very good point actually. Then these are practical points, and this is the benefit of having some very experienced senior surgeons like Rajendra sir into the panel. Because normally, see, in MBBS final year also we get obstructive jaundice as our case presentation. In MS exam, we get obstructive jaundice. At and FCH level, that has to be some difference, and you should know everything, because after this, you are directly going into the practice, isn't it?
Yes.
So, why PTVD? If PTVD, what is the need of PTVD? Like, suppose even if the bilirubin is 14 and the patient is eating well, no issues at all, then why to decompress the system? Suppose there is complete transaction on MRCP.
Yes, sir.
Everything is complete transaction. You are not expecting, like sir told about partial main duct injury, where you just close allow the lateral drainage so that the fistula heal. That is one of the basic principle of any fistula.
Yes,
But
sir.
suppose there is complete transaction, bilirubin is 12, no cholangitis whatsoever. Then are you still trying to do a PTVD? Then just give us your personal opinion on this.
Yes, sir. So I won't prefer, sir, to put PTBD, sir. If patient doesn't have any cholangitis or patient is taking diet adequately, yes, sir. And nutrition.
These all decisions you have to take few months from now. You are into which year now, Dr. Azhar?
Second year, sir.
Okay. So maybe a year from now you have to take all these decisions. So these are very, very good practical point which most of the textbooks will miss out. Okay.
Okay,
Please
sir.
continue.
So MRCP was already was done from outside. This done on the December, sir, before presenting to us. So this.
What is your interpretation of this MRCP? Yeah, please pause here. Yes, tell us now.
Yes, sir. So here there is mild central IHBRD is there with the visualization of the both right duct and left hepatic duct, and both forming the confluencer. And there is and the distal CBD also I can visualize here with.
What does it mean if you are visualizing the distal CBD on so is this a partial injury or can it be a complete transaction only?
Sir,
Distal CBD is visualized.
this maybe but there is in between, sir, not getting opacified. So
Just tell us your opinion. What is? This is
looking like
very, very basic. Actually, I'm asking whether the bile is flowing into the CBD. What does it mean if there is a distal CBD opacification? Because if there is distal CBD opacification in PTBT gram versus distal CBD opacification in MRCP, this is a very basic question I'm asking. What is the difference between the two?
so distal CBD opacification in PTBT gram, that may be some distal continuity is there,
Yes.
and in MRI, sir, I'm not sure, sir.
You have to be sure there is no opacification whatsoever for around roughly 1.5 to 2 centimeters area. So whenever there is bilateral opacity, any static fluid will appear white on MRCP, isn't it? Like renal calyces, stomach, bile, and pancreatic duct. So it doesn't tell you anything because the beach wala portion that is not at all visualized. Okay. And at MCH level, I hope Rajendra sir will agree with me. You should tell more about this MRCP. You just cannot tell left and right duct are joining. Just can you tell us more about the ducts, whether the right posterior duct you are, because the right posterior duct here, it is also seen properly. That is why I asked you to freeze it. So you can just tell us that there is no, all the ducts are right anterior, right posterior. Even I can see a separate segment 6 duct here. You can just tell us that every duct is properly seen. Just left and right duct joining is okay, but at MCS level, I think you should interpret it more in a proper way. Rajendra sir, please you.
I agree, Dr. Pattnaik, that he needs to tell us more. There's a lot of information in that MRCP. Go through all the films and tell us.
Sir, we got only this only, sir. This was done from outside alone.
You didn't
So
get a CD?
no, sir. CD I didn't get. We requested to them, and with pen drive they give this much only, sir. Yes, sir.
I say this is Merizi syndrome. How do you say it's not Merizi?
Just think it as a pre-operative MRCP, okay? And just sir is telling it is Miriji.
There will be, sir, peripheral
First
GB.
try to see the gallbladder. First
Yes,
try
sir.
to see the
Yes, sir. So GB is not visualized, sir. And
So this is a post-operative film. You won't get a GB.
yes, sir.
And also in the pre-op ultrasound, it was written GB is well distended, filled with multiple stones. How can this be Merizi? Unless they are given a wrong report. See, you have to remember what you yourself have spoken. When you're interpreting it, if you keep an open mind, there is a clear cut. The posterior sectoral duct is not draining clearly into the bile duct. There is a pool of contrast there or a pool of collection there. That exactly.
Yes, sir.
So could it be an injury of the right posterior duct emptying into this thing, and there is combined injury of both, and the duct has slipped, the duct like a clip has slipped off and it's became a collection, while the injury to the main bile duct is presenting like this, a type B type of injury, and which subsequently became a type C type of injury. That needs to be kept in mind. You are very likely to miss that posterior sectoral because it's not visualized. If you think that the right hepatic duct is that long, then it's difficult to imagine that it's that long. Usually this length will be 1.5 to 2 centimeters. This is almost showing a common duct sort of extension. So you should think that the posterior sectoral duct is not visible, and this is actually the anterior sectoral duct that is appearing in continuity with the right hepatic duct. What do you say, Dr. Pattnaik?
Yes, sir, very true. Also, some very minor things like you just always mention while telling about the MRCP, whereas there is the first thing which Rajendra sir told you at the beginning of the presentation, where there is common bile duct stones or not. That also you see. Forget about this MRCP. Suppose there is some continuity and collection, you try to keep it that in mind as well. Obviously, there is some haziness around the segment 6 duct area. So that also you can tell it is a type E injury now, main duct plus E5, where the main duct is gone and associated with a segment 6 or right posterior whatsoever. So that has to be described at your level. At least you should know about it. And just tell us about the repeatedly doing MRCP. I have seen people coming to the setup and having 5 MRCPs in hand over a period of 4 months or 5 months before they present to the hospital. So why is it necessary? Like it is all about anatomy. Now it is seen, like sir was telling, it was, sir also gave a hint. It was a type 2, now it is going towards type 3. So what is your viewpoint before operating these patients? You get a recent MRCP or you just take it? And if at all you repeat, at what interval you will try to repeat and why to repeat?
Sir, I don't want to get repeat MRCP, sir. There is no peripheral eyes wear and already PTVD is there. So before,
When will, Dr. Azhar, when will vascular injury manifest? That is the aim of the question. When will you repeat an investigation to rule out vascular involvement?
sir, 3 months, sir, from the
So it is 3 months, so you'll repeat it. So why did you say I don't want to repeat it? What is the importance of vascular injury?
sir, in vascular injury, that stricture may further progress to the proximal, and it will take time to complete to form the complete stricture formation, sir.
I say there is no portal venous injury in this patient. Am I right or wrong?
This question is based on finding of the intrahepatic bile ducts. Okay, I'm just giving you, because we are closing in now. Time is almost up. So what is the meaning of this question? By looking at the MRCP, can you guess whether there was a portal vein injury? Hepatic injury, artery injury, you may not tell now, but portal venous injury. Is there any left portal vein injury or right portal vein injury in this patient?
What is the importance of that?
Especially three months after the primary surgery. It's a long time now.
Patient may develop atrophy hypertrophy complex, sir.
Yes, yes. So there will be crowding. Okay, isolated crowding will be there.
Yes, sir.
That so MRCP will also tell you that. Like I was telling, there are many practical points which will come up while discussing.
Yes,
So, is there any other thing you were trying to tell, sir, Rajendra sir?
Yeah, tell me. What is the
Yeah.
importance of hypertrophy atrophy complex for surgery?
There will be, sir, a rotation of the hilum, sir. So,
Okay.
so the duct basically it will go in the more right and right posterior side, and that portal vein handle will come more on the anterior side. So it will be very difficult to get access to the duct, sir.
Yeah. The other thing is you have not mentioned that there are no visible stones in the bile duct, not in the lower end, not intrahepatic, because multiple intrahepatic calculi can develop over a period of 3 months of biliary obstruction.
Yes, sir, possible, sir. Yes, sir.
That's also important. Hepatolithiasis. Yeah, please go ahead. What do you want to do for this patient?
If you agree, we will conclude it in 5 minutes, sir, from now.
Yeah, sure.
So, what is your view on doing a CT in this? What type of injury you are going to do CT? You do in all cases, you never do, or you selected cases you do for a CT, see triphasic CT or CT angio kind of thing before committing to surgery.
Sir, before doing surgery, I will get triphasic CT, sir, to
In
look
all
for.
cases, suppose it's a type 2 injury, then also you are going to do type 1 injury, suppose E1, bismuth E1. The long stump is there, you want to do. I'm just asking you.
Yes, sir. I'll get, sir, like for at least one purpose, like for medical legal documentation.
Documentation is there on MRCP, the bile duct injury.
Sir, whether any arterial vascular injury is there or not? Yes, sir.
Only for medical legal purpose you are doing a CT, or what else you want to see?
Yes, sir. If there is vascular injury is there, then
What investigation you want to do before doing a CT scan in a bile duct injury patient?
Yes.
Would you like to do a plain X-ray? If there are multiple clips in the GB bed, what will happen in a CT?
it will give, sir, artifact will come, sir.
Yeah, precisely. You won't be able to see anything. So you have to get a plain X-ray, rule out multiple clips,
Yes, sir.
get an MRCP, MR angiogram instead of a CT angiogram because of the risk of artifact. If there are only 2 clips, you can go ahead with a CT angiogram. Even there, it'll be very difficult to make out the right duct, right artery.
Okay, just proceed. Maybe 2 minutes from now, 2-3 minutes you have. You just show us if you anything extra you want to.
Yes, sir. So CT also we got, sir. CT showing, sir, liver shape is not liver shape is normal, no nodularity. with normal enhancing pattern, sir. And I can, there is mild central IHBR is there, sir. And multiple clip is seen in the hilum with one Malicot catheter tip seen in the ductal system, likely the left ductal system, sir. And also the both the main portal vein and the left and right portal vein both are visualized and well opacified, sir.
What about the artery, right artery?
Sir, I'll come to the arterial page, sir. And
In
the
which page it is saying?
spleen size also is normal, sir.
There is no atrophy.
There is no atrophy or hypertrophy of the liver, sir. Should I go to the arterial page, sir? So here we can see the celiac trunk, and this is the common hepatic artery. So here I can't visualize the right hepatic artery properly, but there is some collateral is there supplying the segment 6, 7, and
Why you cannot tell about it is nicely seen. Why you cannot tell about the right hepatic artery? Even you can see the right anterior hepatic artery and right posterior hepatic artery here.
Sir, but as the caliber size of the left hepatic artery, it is not in that size, sir. So I think it may be the collateral also, sir.
Arterial collateral, you need to be slightly careful before telling, because right posterior artery is well going into the main trunk of the right artery, because that is coming off well, but you need to trace the right anterior artery is also, yeah, it is also joining. Okay, so is there any more slides you have? No.
No, sir.
Okay,
What is the report, sir?
Yeah,
Show the report.
there is nothing written about the artery.
Yes, sir.
Vascular injury, extravasation of contrast, nobody is expecting now, no? Extravasation of contrast. So you need to discuss with the radiologist and give your clinical input as well.
Yes, sir.
So before we conclude, I will request Rajendra sir to give his expert opinion about what all you should keep in mind pertaining to this particular case, and then we close.
Yeah, I think we've covered the topic sufficiently. But what is your surgery going to be? Tell us your surgery.
Sir, according the MRI picture, it is looking like, sir, type 2, E2 benign biliary stricture, sir. So I want to do, sir, proper ductojejunostomy, sir, with adequate stoma size, sir.
Is there sufficient dilatation for you to do a sufficient procedure? What kind of technique will you use for the biliary enteric anastomosis? By whose name is it known? Hepkuinos approach. What is Hepkuinos approach?
This is, sir, lowering of the hilar plate from the base of the segment 4B, sir.
You want to do that?
Sir, in this case, I don't think, sir, it is required, sir. So,
You want to do an end to side?
no, sir. I get row and Y side to side, sir. I will extend the.
Where is the bile duct?
I will extend to the left ductal system, sir.
Okay, isn't that before extending into the left duct system? Don't you have to expose the left duct?
Yes, sir.
So that is what is Hepkuinos approach, right? Do you want to extend it into the right duct?
If I get the adequate length, sir, like 2 to 2.5 centimeter, I will not extend, sir.
Okay, why do you want to get a 2.5 centimeter opening?
So after even after biliary anastomosis also, that some form of maybe some stricture may develop, sir, to get the adequate stoma size, sir.
Any questions, Dr. Pattnaik? I think we can close.
No, sir. It is already time, and it was very good discussion, and you have also presented it nicely. And whatever points sir and me told, you just take it positively, how to improvise yourself, okay? And just try to fit into the clinical picture next time you kind of, because I'm sure you must be seeing a lot of case at AIIMS Rishikesh.
Yes.
So you just try to put this experience or theoretical part into clinical picture, then definitely you will see your improvement as well. Okay. It was very nice discussion. Thank you, Rajendra sir, for your time. to the
Thank
residents.
you, Dr. Pattnaik. You also. But
Yes, sir. And I hope we can be on the same platform in future as well. Thank you, Dr. Azhar. Thank you so
Thank you,
much.
sir.
Thank you, Dr. Anna. So we are closing. Thank you.
thank you, Dr. Anand.
Okay, we are leaving the session. Thank you. Thank you very much.